Hi, everyone. I would like to welcome you to the webinar. My name is Michal Tavrovsky, and I lead product innovation at MenHealth. We would like to thank Logba for hosting this Innovation Theater program and for being such a great resource and platform for innovation in the urology community. And I'm honored to introduce our guest speaker, Dr. Craig Cometer. Dr. Cometer is a professor of urology at Stanford University School of Medicine. And Dr. Cometer has been practicing urology for more than 18 years. He has been principal investigator on numerous clinical trials regarding treatment of male and female urinary incontinence, overactive bladder, neurogenic bladder, and BPH. And he's the clinic chief of urologic specialties and the director of the Stanford program in female pelvic medicine and reconstructive surgery. He has served on the board of directors for the Society for Urodynamics and has had leadership roles in the Western Sectional and National AUA. And after the presentation, you will have an opportunity to ask questions. Please use the questions box on your screen to type up your questions. And I'm going to turn over the mic to Dr. Cometer. We can begin.
Okay, well, thank you, and I'm honored to be here. If anybody has any questions, it's best if we save them to the end. I will certainly leave time for that. And I'm going to see if I can actually teach you all a little bit about uroflowmetry, some stuff you may not have known before I get into the details of this latest innovation. So I want to disclose I am an investigator for BE Technologies and a scientific advisor. And let's start with uroflowmetry. Most of us know this is the simplest way to assess voiding function and dysfunction. It measures your flow rate. And it's often possible to confirm obstruction. Low flow can confirm obstruction. It's a device that measures volume per time. And then we often couple it with the residual urine to see if the patient empties well. This is a very important part of how you evaluate male voiding dysfunction, but a single flow does not always give us the right answer. We know that even a proper flow can vary with the time of day. Obstructive symptoms are worse at night. I'm experiencing that myself. You get up at night, the flow is worse, probably from alpha adrenergic agonism, and the epinephrine is contracting the prostatic smooth muscle capsule. Bladder volume varies, voided volume varies. Too low a volume is just an inaccurate test. Medication can vary. These pills don't last for 24 hours, so they may wear off certain times of day. And we know that flow varies with gender and age. So we don't want just one flow, we want many flows. But in the office, we get one, and it's to screen for bladder outlet obstruction. We check the maximum flow rate. Some folks look at the average flow rate. I don't. And we look at the flow time, the time to maximum flow, and the total flow time, which is just a fancy way to say we look at the shape of the curve. We look at the upstroke, where's the peak, and is there any intermittency on the flow? So you can see here on the right, this is just a real-life flow. It's got a nice little artifact that we all know we can ignore. That's just a little WAG artifact. But in this classic flow, you get a peak at about 1/3 into the flow, and then it declines over the final 2/3 of the flow. So on the left, I show an unobstructed flow. All of us would read this as good peak flow, inverted U shape. Maximum flow rate almost 20 mils per second, and it's a unimodal shape. On the right, this is an obstructed patient. It's a low flow of 7 milliliters per second. The shape of the curve is still unimodal, but you have to think in the back of your mind, could this just be a weak bladder? It's not easy to tell what's obstruction versus what's a weak bladder based on Uroflow alone. So here's what we were taught during residency and what we keep hearing at meetings. Maximum flow should be 15 to 30 milliliters per second, depending on age and gender and voided volume. Less than 10 is low, and that's when we start to think about obstruction or a weak bladder. 10 to 15 is equivocal, and greater than 15, we say, if not normal, it doesn't sound like you're obstructed. And then the average, the flow time, the time to max flow is not as helpful as just good old-fashioned Qmax. So that's what we learned, but here's the data. If we think of the lowest acceptable max flow rate for a good volume, 200 cc's, as one standard deviation below the mean, this is what we get. And I picked one standard deviation because that'll capture 2/3 of the patients. So about 16% of the people would have a low flow, meaning less than one standard deviation from the mean. 14 to 45 in men, that's 12. Same thing if you're 46 to 65. So we're not seeing a big drop off in that age of 45 to 65. So anything above 12 is more than a standard deviation from below the mean. And then 66 to 80, 9 mils per second is where you hit that lower 16 percentile. For women, not as high as we're taught in the books. 15 mils per second, age 14 to 65, will get you within a standard deviation of the mean, and 10 for an older person. Turns out volume really does matter. We all know that a small volume can create a weak flow. Just think of yourself. If you void and someone tells you to void again 10 minutes later, well, there's not much in there. It's going to come out slowly. But there's an efficiency at 400 mils. After that, you're overfilled, stretch injury, the detrusor doesn't contract well. Lower than that, you haven't maximized your Starling curve. So you can see on this graph, obviously, the low volume flow of 50 mils total, you have a sad little flow. But you see that you get the peak flow when your volume is 400, and you start to lose that peak, probably from lower contractility if you overstretch the bladder. So there is an efficiency mechanism where 400 is the ideal capacity for the bladder. Detrusor underactivity versus obstruction. Well, they're the two most prevalent conditions that affect the voiding phase of men. So how do we distinguish? It's difficult. The symptoms are similar, weak bladder or obstruction. And traditionally, we use pressure flow studies to distinguish between them. Low pressure, low flow is a weak bladder. High pressure, low flow is obstruction, but it's invasive and it's expensive. So we can use flow to determine if there's overactivity or obstruction in many instances. Here's an example of detrusor overactivity. Supranormal flow rate, rapid upstroke. This is detrusor overactivity. The man's bladder is contracting as he's unzipping the fly in the bathroom. His sphincter is contracting so that he doesn't wet himself. And then the sphincter springs open, bladder's already contracting, so you shoot the urine out, rapid upstroke, rapid downstroke. This is obstruction. How do we know it's not weak bladder? Well, there's an early establishment of maximum flow, as opposed to here, where the max flow is in the middle of the voiding curve. So early max flow is diagnostic of obstruction. Max flow in the middle of the curve is diagnostic of a weak bladder. Now, a lot of these patients, we will get urodynamics to confirm, but if you know this little trick about uroflowmetry, you can take this man with obstruction right here with the initial peak straight to treatment, straight to surgery. Here's a box pattern of a urethral stricture. Fits that pattern of early peak flow. Again, a very low flow, about 5 milliliters per second to 10 milliliters per second, but it occurs early. And it is prolonged without falling off till the end because that stricture is right near the meatus. Here's an obvious pattern that we've all seen, this straining to void. Don't know if it's obstructed, don't know if it's weak, but it's definitely a strain to void. So how can we tell if this straining is obstructed or weak bladder? We do a choke flow, penile urethral compression and quick release. This is something I noticed when I was a resident working with Dr. Yala, that these men would squeeze the urethra, build up pressure and release, and that would help them urinate. And it turns out if there's a high surge compared to the steady state flow, they're obstructed. In other words, squeeze the urethra, build up a pressure, isovolumetric, release the urethra, and that high pressure results in a high flow. Whereas if they have a weak bladder and they squeeze the urethra, they will not build up a high pressure, they'll build up a low pressure, and here are the graphs. The top patient has a weak bladder because when he chokes the urethra, he gets a really little spike. So the Q surge minus Q steady state divided by Q steady state is not very high. While with obstruction, there's a giant Q surge because he has a high pressure that he's building up. So Q surge minus Q steady state divided by Q steady state is quite high. So that's how we can diagnose obstruction in a patient with a low flow. You can also see that you're going to get a high Q surge with detrusor overactivity because when you have overactive bladder, in other words, spasms, and you don't want to wet yourself, you're going to clamp your urethra, the guarding reflex, guarding reflex, and you're going to have this isovolumetric contraction. So you're going to get a big surge. But what makes this different is your steady state flow is high. It was 20 mils per second. So we could diagnose Detrusor overactivity based on Uroflow. But a single flow is not good enough. Doctors Kaplan and Tay showed us this. They did 20,000 Uroflows, and they found that multiple measurements performed at home provide a more realistic assessment of true behavior, better than just one flow. So what's the future? Well, it's not the future, it's the present. Home urodynamics. There are health apps that already exist. Repeated measures of flow is better than any single measure at just some random time. And now computers, iPhone computers, Android computers can assist and create an average flow curve. So it could even do some math that we're not capable of and correct the Qmax for voided volume. So here's an example of a Uroflow based on this novel audio uroflowmeter. And you can get multiple curves and you can average them out. So here's dozens of flows, and the blue line represents the true average flow curve. So what is this app? Well, the Men Health Uroflowmetry app was created to obtain the main urine flow parameters from patients at home. It's FDA cleared, it's HIPAA compliant. You start it, gives you a countdown, and you void, and it measures flow based on sound. It's a patented technology. It acquires the sound of the urine splashing in the toilet, and it calculates the maximum flow and also the average flow and the voided volume. So you see on the left the test result. You can do it in diary form. You can pull up the patient dashboard. And you get this physician report where you can see anything and everything that you want to. You can have multiple flows giving you an average graph. You can have tabular form. You can look at individual curves, click on them, and get the actual flow curve from any point in time. So we did a validation study. Validated this Men Health mobile touchless audio uroflowmeter. We said it processes the sound and it measures flow rate and volume. This would be ideal for ambulatory home uroflowmetry, and it would be unlimited. And it has to overcome this limitation of forced urination in the office, regardless of time of day, medication status, or bladder volume. So it was two dudes. One was young, one was not so young, and they each voided 50 times. 22 using a standard uroflowmeter and 28 using the Men Health app, and we compared max flow and voided volume. And you can see no important difference. The flow rates were nearly identical. The voided volumes were statistically insignificantly different in both the normal flow person and the low flow person. You can see that the variation, not due to technology, but variation due to the variability of flow rates over time, again, depending on hydration, medicines, and time of day, was equal. The error bars are the same, whether you use the standard uroflowmeter or the audio uroflowmeter, so no difference. And you can see maximum flow rate, voided volume, no different in participant 2, the one who clearly has BPH and obstruction. There was a separate validation trial where we took 31 men, and basically this was in the days when the thought was maybe this app would be used by individuals at home who were just curious as opposed to a true medical indication. And we asked them what they thought. 90% said it was easy or very easy. More than half said they would test their Uroflow every week or several times a week. 3/4 said they would conduct self-testing once per month or more. Almost all said they would purchase it if the physician recommended it, and all said they would use it if it didn't cost them any money. Here's another validation study. So they looked at men over 18. Group 1 was almost 50 volunteers with symptoms suggesting OAB or obstruction, and group 2 were men without complaints. And again, comparing the audio uroflowmeter to a standard, this one was a Prometheus uroflowmeter. Again, no important variation. A correlation coefficient of 0.91 means virtually no difference between the two technologies. In other words, the audio uroflowmetry device accurately captures the flow and calculates the flow rate and the voided volume. So the Men Health phone app is equivalent to standard uroflowmetry machines and is therefore useful to do at-home uroflowmetry. You can sort the data. Here's on the left, the history. You can look at each flow. And again, I only really look at max flow, not the other things average, and the voided volume. And on the right, there's a diary. So this technology is also a great way to get a true electronic voided diary. You can sort the data. So you have a screen that says you want to look at it from last week, last month, 3 months, and then you can plot out not only an individual curve, but the average of the curves calculated. So this patient here has an average max flow of around 7 or 8 milliliters per second, someone who clearly has a low flow. And this excuses the occasional flow that was up to 12 and the occasional flow that was down to 2 because we averaged it out. Even more manipulation. So lots of flows, and you can get a perfectly smooth Uroflow curve here. This is someone with a typical or averaged max flow of around 12 milliliters per second. And here's someone who has a much lower average maximum flow rate. So this Uroflowmetry app, it's software-based. It's been clinically validated with a correlation coefficient of greater than 0.9 compared to standard Uroflowmetry. It is FDA cleared and designated as a uroflowmeter, and there's multiple patents to protect it based on audio uroflowmetry. It's very simple to use. It was created to obtain the flow from a man at home any time of day, measures everything that we would get in the office, max or average flow, voiding time, voided volume. If you want, you could look at hesitancy time. That is, when did they press the button? When did flow start? You can look at the specific date and time. It's a bladder diary, and it also will capture the BPH symptom score because it prompts the patient. The device listens to the splash when you hit the water, and that curve is superimposable upon a standard uroflowmetry curve. Different screenshots. You've got a diary, you've got the tabular form of the diary or the graphic form of the diary. Your dashboard says what the symptom score is and the quality of life, and then the flow averages. And you can also just look up the symptom score. You can see all the patient's test results, including voiding diaries, by just clicking on the table, and the individual and average flow traces can be analyzed and exported by the physician to the medical record. So it works in conjunction with MyFlow and this so-called end-to-end remote urinary monitoring system that allows not only real-time monitoring, but the patient can communicate with the provider. It's very simple. You bring up the app, you press start. It not only gives you a countdown to get ready, but it measures the background noise so it can eliminate it. It gets rid of the sound of the zipper opening so that you're truly just measuring the flow. And again, you could pull up on the dashboard the individual flow, symptom score, diary, or the average graphic flow. Better than the paper. When I ask my patients to do an IPSS or AUA symptom score, they'll circle 2 scores. So I don't know, is that a 3 or a 4 because they circled them both? This one makes it easier. They can only pick one answer and then they get locked out. So it actually simplifies the AUA symptom score, and we don't have to deal with patients who circle multiple answers. And then there's the quality of life questionnaire. This is the physician platform. So here's a fictionalized patient. You just pull it up. It gives you the history that we've entered. This is somebody who had a resume in April, takes Flomax, and you could look at all of his results, and you could sort if you want by max flow, by voided volume, by voiding time, or I find it better in chronological order. You can click on each flow to see what happened. No need to. This one's a max flow of 17.7, so it gives you all that data, but you can always pull up an individual curve. This is shows you can have the table on the right where you see everything. Much easier to just press the button that says to graph the results, and I look at the red line and say, okay, that's a max flow of between 5.5 and 7. That's a low flow. But you'll see there's a couple of winners up there where there were some flows over 10. You know what? It's not an error. It's just that it's variable. But for the most part, this person has a low flow. You can communicate. So here's a patient that says, I'm still having problems. Then he follows up. Things are getting better. And you could write down everything's great. So how do you get paid for this? Well, the CPT code for Uroflow 51741, there's a professional fee, you interpret the data, and there's a technical fee for owning and maintaining the equipment, and the place of service at home would be a modifier 26. But you should not bill more than one per day. That's what the AUA says. You can, and if you're gonna bill for doing the flow, you cannot then use it when the patient comes back to the office as part of the data section of the medical decision making. It's one or the other. You either did a flow at home or he brought it in and you put it in the data section at the following visit. You can choose to not look at it real time and just use it for the data section, but either way, it is reimbursed. Home Uroflow can be transmitted to the provider, obviously needs to be HIPAA compliant, or it's just brought in at the next time of the office visit and you just document the place of service is in the office. We don't really get to bill for supervision or the technical component because that requires direct supervision. He would need to have a video visit with you with the camera visualizing the uroflowmetry. So we lose the technical component and you only get the professional component. Does not count, according to the AUA, as remote physiologic monitoring. I know when I go to my cardiologist, he slaps the Zio patch on me and he gets a lot of credit for it because that is constant. This Uroflow is not continuous, so we cannot bill for remote physiologic monitoring. But this is what I got from the AUA website, specifically Urology Times. The frequency or number of tests is being studied. Currently, there's no limitation to Uroflow tests outside of the 1 per day limit. So payment for multiple flows provided on different dates is allowed by many payers. And it should, in my opinion, become the norm. In a different AUA click, I just kept Googling it. The AUA had recommended 7 studies as reasonable. So I say daily for a week. So here's the potential for income. Complex uroflowmetry pays between $14 and $15. This is a little old. It's actually gone down to $14 from what I understand. Professional fee is about $8.50, call it $9. The technical component is $6. So if this is done at home, you lose the technical. So you've gone from $15 down to $9. But you're going to do it every day for a week. In addition to getting more flows done, they should be more useful because in the office, 15% of my flows I just don't get to bill for because the patient couldn't void. Of course he couldn't. He just gave a urinalysis because I followed the guidelines and checked his urine. Sometimes the machine was off, printer's out of paper, mechanical malfunction. I don't know why it didn't work. And believe it or not, it happens about once a month. Patient pees in the sink. I have no idea why a grown man would decide to pee in the sink when there's a Uroflow funnel over the toilet, but it happens every month. And then in addition, 25% of these flows, they're really not good enough. They're low volume, less than 150 cc's. So you'll get paid for it, but it's not very useful. So how much could this be worth to my practice? Well, I see 75 patients a week, 40 are men, the other half are women. I'd say about 25 get a Uroflow. So 25 times $14 is about $350 a week. But if I converted this to home Uroflow, remember I get paid less, $9 per flow, but I would do 7 of them. So that's $1,575 per week for a difference of over $1,200 per week, which 48 weeks, because I don't get as much vacation as a lot of people, I get 4 weeks. That's $58,800 annually for me, one person, not as busy as most of the private folks. Half of my patients are women, so not getting home Uroflows. And I could probably justify another 7 per year because you can do this every 6 months. That's very reasonable. The only reason I do it, see these guys once a year, is I don't want to torture them or torture me bringing them in. But doing 7 Uroflows at home is just free and valuable information. So my math says a Tesla costs $58,990 here. I live around the corner from the Tesla dealer. 10% tax in California, we're very high tax. But then we get the rebate. So it's going to be about $57,389. And with just me using this device, I can collect enough to get a Tesla every year. Well, what about people who are busier than I? So again, using this idea of about $865 for the reimbursement per test versus the office of closer to $15. If you do 50 patients a year, the difference, 6,000 minus 1,500, is about $4,500 a year. Obviously, you do more than 50 a year. So if you're up to 1,000, that gets up to $91,000. And if you're doing 5,000 Uroflows per year for a large group practice, that's $450,000 extra income. And you're getting better, more reliable, more useful, and more ethical studies and data. So here's my Uroflow, and I mean me. So you can see some of these flows were great, some were pretty low, but when you average it out, good. I'm between 15 and 20, so I'm better than a standard deviation below the mean, and it looks like everything's good. So you can see how this home uroflowmetry can be very useful, not just for the doctor, but for the individual who's curious. So here's my final thoughts. This increases the utility of Uroflow. This is not just something to increase billing, it actually improves the study by doing it several times, 7 in a row. It also gives you an accurate voiding diary. One of my pet peeves is when we do a clinical trial and they say we want an electronic voiding diary. Well, it's not electronic. It's entered by the patient into an electrical device. And we've had studies, specifically the Mirabegron study, where 100% of our patients were excluded because they didn't do the diary accurately. You get locked out because if you don't enter your void within a few minutes, you didn't void. But this is a true electronic voiding diary because it catches it in real time. So you don't have to enter any data. You just turn it on. So it's better data. It's more accurate. A week of flows with an average graph gives me more confidence and far superior to from a single Uroflow. It can replace office Uroflow. So you don't need that expensive Uroflowmeter in the office that breaks, that gets gross and you have to clean it, and the ick factor of the medical assistant spilling it out and washing it. And think about the Uroflow pain points. I want to get a flow. So I step out because I have to go see my other patient and I say to my medical assistant, can you get a flow and a residual on this gentleman? Well, she's got to get the patient, bring him to the bathroom, get the printout, clean the funnel, collect the device, find me because now I'm with another patient. That's probably 10 minutes of room time. We have very high benefits here. About 35% of the overall compensation is benefits. So we probably pay our MAs greater than $50 an hour. 10 minutes of her work is already $8.50 for this $14 test. So you're really not losing any of this money when you do it at home because you get rid of the labor cost. It doesn't change the indication for Uroflow. We're still only doing it when I need to know what's your flow, what's your voided volume. But the increased revenue to $63 for a week of home flows versus 14 in the office is quite a bit for something that improves the utility of the test. And then after looking at the data, you can decide, do you want to bring the patient in for the visit? This doesn't take away the visit if that's part of your flow. It just adds to it by giving you data. Or you can say, nope, I have your flows. I don't need to bring you in for this return patient visit. I can save that slot for a new patient. So in summary, this is a device that improves the uroflowmetry that we're doing. And by the way, provides an opportunity for increased revenue generation. Thank you.
Great. Thank you, Dr. Comer. So we would like to open the presentation now to questions, and everyone has a questions box on their screen. So I encourage you to type in your questions and I'll be reading them out for Dr. Comer to answer. And our first question is, how does the data compare between men's health and a traditional office uroflowmeter?
So when you compare the two side by side, it's superimposable. So we initially started by pouring water into a splash container, and we recorded it, and that splash container was, at the bottom of the uroflowmetry machine, and it was superimposable. But again, when we're comparing one to the other, they're not done simultaneously. So in these validation studies, we showed that they were nearly identical. So I would say they compare very favorably. I would call it identical. But remember, there is variation. So 7 is going to be more accurate than 1. It may be different, but it's going to be better.
So another question that we have is, does the interpretation have to be done by MD? Can APPs interpret and build a code with a 26 modifier?
So I am a salaried person. I don't do a ton of this billing and coding. This was the hardest part of the talk because I had to Google it all and learn it. But I think the answer to that is yes. A provider who interprets the results will bill for it. So just like an APP will bill for doing Uroflows in my office, the APP will bill and collect for doing home uroflowmetry. It is not necessary that you have an MD degree to do this.
So another question is, how much is the app and who pays for it? I guess, this is something that I would be happy to answer offline after the presentation, and I'll give my contact information. But the provider pays for a subscription to be able to use my Uroflow platform, so the patient doesn't pay anything.
Right, and I just want to echo that I'm an investigator, so Stanford is very strict about conflict of interest, so I cannot use this to generate revenue because I'm an advisor and an investigator. So I will defer to Michal for any of the financial questions of how it costs and how do you use it.
And then another question is whether it's reimbursed for complex uroflowmetry, and yes, this is actually the code that how this is reimbursed for the complex uroflowmetry code.
Right, so remember, simple uroflowmetry is just measuring volume and using your stopwatch. So this is indeed complex uroflowmetry, and again, if you use the audio uroflowmeter in the office, you get the same $14, $15 as if you used a regular uroflowmetry machine, but you don't have to clean it up. When you use it at home, it is still complex, you just lose the technical components, so that's why it goes down to $9 from 14 or 15.
Another question is, if patients do not have smartphone, is there some sort of phone we can load them? I mean, it is possible, yes, definitely. And you can also have a phone in the office, so you can use it in the office as well.
Right, so remember, in the office, you can have a phone or an iPad. I have put this on my iPad and it worked. So that one's easy. But simply, if the patient is just not into the 21st century and does not have a smart device, then no, they can't use it. And that just happened to me this week. I put in the wrap-up section of my note that's visible to the patient on My Health, and his answer to me was, "What's My Health?" And then I said, "You just check it on your phone." And he says, "Oh, I don't have one of those phones." So there are going to be some patients who can't use it at home if they don't have a smart device. But it's pretty rare, at least in the Bay Area, that someone doesn't own a smart cell phone. And My Health is ubiquitous here because that's the way we communicate. So they pretty much all know how to press a button.
So there's another question. Does the data from the app integrate with providers' EMR? And I guess I can answer that because this is definitely something that we can work out, and depending on what platform you're using, yes, they can be easily integrated.
Right, so it's not automatic in that it's built into the machine right now, but yes, and that's the job of BE Technologies to make sure it's integrated because it's got to be seamless for the doctor. So yes, it can be integrated. It must be integrated.
Yes. Another question, are we missing an opportunity to intervene sooner when men have normal flows but are starting to have commissary elevated Detrusor pressures?
That is a great question because it has nothing to do with the technology. And the answer is, I don't think so. So think about the patients that you see who come in with hydronephrosis and renal failure. To me, 95% of the time, that's someone who says, I was perfect. I was going every 3 hours, sleeping through the night. It's a lightning strike. It's an unpredictable thing. I can't remember the last time someone decompensated, went into retention, or developed renal failure under my watch. So I'll be honest, I don't know that early intervention is going to save kidneys and save bladders, but early intervention certainly can't be harmful. It's only good for you if we relieve obstruction early on. So maybe we will improve quality of life, and maybe we won't accept nocturia as the normal consequence of aging. I tell all my patients you should wake up once at 60, twice at 70, 3 times at 80, because that's normal. So maybe there is an opportunity that if we knew your flow is going down and we could show you were obstructed in your 40s, maybe if we treated it then, people will be sleeping through the night at 60 and 70, and we will reduce obesity, diabetes, and all these things that can result from sleep deprivation. So great question. We don't have any data to support that early intervention is helpful, but I think we have an idea that it's certainly not harmful, and it may indeed help.
Can you integrate with Eurochart EMR? And we haven't actually, we haven't done that yet, but this is definitely something that we can look into. And for us, it's pretty simple to integrate with any EMR really, and build APIs. And then another question, will we get copies of the slides after the presentation? So we are recording this session, and you will get an email link with video link, so you'll be able to see the presentation.
Okay.
Are you concerned about influencing critical decisions made by the patient when sharing data with patients?
Not sure what that means, but I share everything with every patient. So to me, this is just a better way of doing the shared decision making. So you probably will run into the obsessive compulsive patient who focuses too much on data, but you know what? He's going to do that with one flow in the office. So I'm not concerned about any adverse consequences of sharing data with the patient. I think more data, more communication can only lead to better decision making. But I think we all know that there are going to be patients who will test their flow 6 times a day and call us for the one bad flow. But it's no different than the person who calls me and says, I woke up last night to urinate. I think I need surgery.
How accurate is this as avoiding diarrhea for women?
Okay, that's a great question. Right now, it is not applicable for women. So it is by far the most accurate way, the only way to do an electronic voiding diary for men, because it literally captures the voided volume in real time, as opposed to relying on the patient writing it down or entering it into a device. As far as women goes, right now, it is not designed to measure flow in women because it needs the splash, and it's been validated and programmed to do the splash of someone who's standing up. But I do know that BE Technologies is working on this to be in women. It's the logical next step, and I don't think it's very difficult technology. It's just a matter of getting the mic either down there in the toilet or having it more sensitive so that it can hear it. So way back when this is developed, it was a microphone on a stand like a music studio. And my wife went nuts because that was in our bathroom when we were experimenting. Then it turned out to be one of those little clip-on mics, and we clipped it onto the back of the toilet seat. So you can imagine that technology is not very difficult. I'm sure they'll do better than a clip-on microphone into the toilet to hear the splash in women. So it's just a matter of the next iteration. It's not difficult technology, but as of this moment, it is not useful for women.
But I do want to say that we are working on the women's version, and we anticipate that soon it's going to be out. And I also want to mention that all the attendees will be, have access to this recording post on the Logbo website as well for the program. How many times do you recommend patients to do Uroflows?
So I recommend it every day for a week, and I tell them to try and do it the same time every day so that there's some level of consistency. Don't have data to say that your hydration status is identical at 4 o'clock every day, but I certainly would think that's the best way to get a flow that shouldn't vary with hydration, because you're bone dry when you wake up in the morning and you're having tons of urinary flow after your second cup of coffee. So I just tell them to do it the same time every day. I don't know if they're listening. It's possible they're doing it at different times, but in the law of large numbers, I think if they do 7 in a row, it's going to be more clinically meaningful than if they just do 1. So I don't stress about what time. I just say, try and do it same time every day. 7 in a row is what I do. And I only do that because when I Googled the AUA, that was what seemed to be their opinion of what's a reasonable number of flows.
Is the pay for subscription by provider? Are there larger group options to reduce the potential expense of 50+ provider groups, for example? And again, like I said, I would be happy to schedule a call and discuss that. And there are a lot of variables. Yes, and that depends on the number of doctors and number of patients and number of Uroflows that the practice does. But yeah, we obviously take it all into consideration. And for a large group, it would be a bespoke solution, let's say, for a group that large. So see if there are any more questions. I think that we run out of questions from the audience, and I would like to thank Dr. Commodore again for his great presentation, for his time. I would also like to thank Lagba for hosting this webinar, and thank you everyone for joining us today. I would be happy to answer any additional questions about men's health and my Uroflow, and you can contact me directly at michal@menhealth.me. And you can also go to our website at myuroflow.com and click book a call button to schedule a call with one of our team members.
Okay, well, thank you very much. Thanks for inviting me to do this. I had a lot of fun, and I hope you guys learned something from it.
Thank you.
Thank you. See you soon.
Bye.